Assalamu alaikum. Welcome to today's cataract surgery insights into my Phaco settings for NS grade 3 cataract. I'm Dr. Abdur Rahman Mohammad going to perform this surgery. Wash the provident iodine from the ocular surface, which is kept for 30 seconds. Stabilize the eye with the cotton bud and make the right and left side port with a 1.2 mm NVR plate, followed by creation of the main port with a 2.4 mm steel keratome. Now stain the anterior capsule with Tryphene blue. Always ensure that you incise the preliminal vessel, thereby you will have a good wound closure after the surgery. The wound will heal very quickly if you involve the permeable blood vessels. Now refill the anterior chamber with OVD and which will flatten the anterior capsule, which will help in the creation of the continuous curvilinear capsular rhexis. Now guide the capsule carefully. Since the nucleus is in the intumescent side, I'm intentionally making the capsule small. Now I decided to spiral out the anterior capsule to make a large rhexis. Always refill the anterior chamber when you feel that the AC is collapsing. Whenever the AC collapses, the anterior capsule bulges up and there will be chances of radialization of the rhexis. See how many times I'm refilling the anterior chamber with OVD and flattening the anterior capsule, which will help me in creation of a beautiful, round, continuous curvilinear capsule rhexis. Always be careful. Move the rhexis flap away from the main port, or if it comes out of the main port, there may be chance of extension of the rhexis. Now over here I have noticed that there is a small area of fibrosis at 3 o'clock area which prevented me from completing the rhexis with the cystidome. So I used the rhexis holding forceps to complete the rhexis, but the rhexis was not nice because it was prematurely completed. Now I perform hydrodissection of the nucleus. In hydrodissection, always remember to tap the nucleus down, thereby releasing the pressure from the posterior capsule and preventing the posterior capsule from blowing out and causing a PCT. I've already rotated the nucleus with the Sinski. Now I'll be performing pre-Phaco. This is my pre-Phaco setting, where a torsional amplitude of 20 is kept and a bottle height of 90 with an aspiration flow rate of 30 and a vacuum of 180 mm of mercury. This is my scalp setting, where there is a torsional amplitude of 90 and a bottle height of 90, aspiration flow rate of 24 and a vacuum of 90 mm of mercury. Sculpt out a central pit for modified chop. My chop setting is in the burst mode, where I have a longitudinal energy of 70, which is kept at linear, and a time on of 200 millisecond with a bottle height of 90 centimeter and an aspiration flow rate of 30 and a vacuum of 400 millimeter of mercury. Now perform vertical chop, which was easy because you were able to bury the Phaco deep in the center of the endonucleus. Now I have created two heminucleus which will be further sub-chopped into multiple pieces. See how effortlessly I'm chopping the nucleus into multiple pieces because I have the dynamic fluidics and the Phaco setting perfectly set in my machine. Some bubble came. Always remove the air bubble before doing anything because this bubble will obscure the vision during the surgery. Inject OVD to remove the bubble from the AC. This is my quadrant setting. It is in the burst mode where I keep a torsional amplitude of 90 millimeter and a time on of 40 millisecond with a off time of 50 millisecond with a bottle height of 74 centimeter with an aspiration flow rate of 30 and a vacuum of 400 millimeter of mercury. Now perform my favorite technique, single-handed Phaco emulsification of the multiple chop pieces. In doing so, I am performing the surgery in the triangle of tranquility, where there is excellent flowability, and in doing so, I am effortlessly emulsifying the chop pieces. See how easily the pieces are coming towards the Phaco tip because I'm maintaining the triangle of tranquility. If you don't understand what is the triangle of tranquility is an area in front of the Phaco tip where there is the maximum amount of fallibility. I like to remove the last few pieces in epinucleus mode where I have a torsional amplitude of 70 percentage and a bottle height of 90 centimeter and an aspiration flow rate of 28 and a vacuum of 280 millimeter of mercury. Over here you can see that all of my setting is in linear mode and is in continuous mode. Whenever removing the last few pieces, use the help of the spatula to act it as a shield and prevent the posterior capsule from coming and hitting the Phaco tip. Thereby you can prevent PCT from occurring. This is my cortex removal setting where I have a bottle height of 100, an aspiration flow rate of 25, and a vacuum of 250 millimeter of mercury. Over here you can see that all of my setting is linear. Always remember to keep the setting in linear, especially the vacuum, because if you keep the vacuum in fixed, you'll catch hold of the anterior capsule and you can cause PCT if you catch hold of the posterior capsule. If you pull on the anterior capsule, you can cause zonular dehiscence. So always remember to keep the aspiration linear and the vacuum also at linear in cortex removal stage. This is my polish setting where I have a bottle height of 100 centimeter, an aspiration flow rate of 8, and a vacuum of 10 millimeter of mercury. Here also all are kept at linear. In polish setting, perform a little bit of capsular polishing. Now perform viscofluid exchange and enlarge the main port to 2.8 millimeter. Now load the IOL in the cartridge. Now I'm implanting the IOL in the PC bag. Dial the tailing haptic in the PC bag with the help of the spatula. For removal of the visco, this is my visco setting where I have a bottle height of 100 centimeter and an aspiration of 30 and a vacuum of 350 millimeter of mercury. Over here, all of my setting is also kept at linear. Now perform stromal hydration of the side port, right and left side port, and the main port with BSS. Now inject intracameral antibiotic followed by subconjunctival injection of dexamethasone, and the case is completed. Thank you, my dear friends. Hope this surgical video was helpful in developing your surgical skills.